To get going. Good morning, everyone. My name is Carol DeAndres, and I am the Stakeholder and Public Engagement Manager here at the California Department of Aging. I'm on the Master Plan for Aging team. I am happy to be with you here today. This is the California Aging and Disability Research Partnership meeting. Or CADRP for short, we call it CADRP. Today is April 19th, 2024, and this is the committee's second meeting for 2024. So we appreciate your being here with us. Can we go to the next slide, Callie? And I will do some meeting logistics for you. As you can see, this meeting is via Zoom webinar, and we don't have ASL for you. So I apologize for the slide. With the CADRP meeting being so resource-oriented, we do not have ASL, but we do have closed captioning available through the Zoom function. So feel free to use that. After the meeting slides, transcript, and recording will be posted, will be posted on the CalHHS Master Plan for Aging webpage. And committee members, if you have yet to do so, if we could get you to rename yourself. Right now, you have a generic CADRP member Zoom display. So if you could please right-click in the upper right of your Zoom display and hit rename and type in your name. We know who is able to join us today. Next slide. A few virtual meeting operations we want to go over. Let you know that the chat function is enabled for the committee members and the California Department of Aging staff to share out meeting related resources and information. The public will be able to view the content shared in the chat today. The chat feature and the question and answer feature are not enabled for comments or questions from public attendees at this time, but we do invite you to hold your comments until the public comment period, which is on the agenda for later in the meeting. We will take your verbal comment at that time. And of course, you may submit at any time written comments to our Engage email box at engage@aging.ca.gov. Next slide, please. Some logistics for the public comment period. Attendees joining by phone may press *9 on the dial pad, and it will raise your hand. And attendees join via Zoom can click the raised hand icon, and we will unmute your line. Please note, comments are limited to 2 minutes so that we have enough time to get to everyone. And again, if you have written comments, you feel free to send them anytime to the Engage email box, engage@aging.ca.gov. Next slide. Committee purpose. The primary purpose of the California Aging and Disability Research Partnership is to, 1, advance age and disability-focused research to strengthen the evidence base for promoting equitable opportunities for Californians to thrive as they age. 2, provide input on key performance indicators and data sources to inform MPA outcomes reports and the data dashboard for aging. And 3, model a research partnership between California state government and academic institutions focused on using data for action and equity that can be replicated across other CalHHS person-centered data-driven priorities. And of course, we couldn't do this purpose without our committee partnership, which is on the next slide. Pardon me. You will see our partnership members from a variety of academic institutions, philanthropic, and nonprofit sectors. as well as government representatives. So we do appreciate the time and your expertise. This is very focused stakeholder committee membership partnership, and we are so appreciative of your time and your expertise that you are sharing to advance the master plan for aging. So can we go to the next slide? Here's our meeting agenda. Just a brief overview. We will have MPA and CDII updates. We will have our CADR priorities for the 2024 MPA Day of Action, update on our LGBTQIA studies. It's going gangbusters. We're so happy with that. MPA key outcomes, revisiting the caregiver burden. We will have a presentation on that. Finally, public comment, and then we will be adjourning by noon. So with that, I will turn it over to Susan DeMorris.
Thank you, Carol. Thanks a lot. Good morning, everyone. I appreciate you joining us. It seems this committee always meets on Fridays. I like that. But I wanted to especially thank you all for taking time out of your day when Taylor Swift's new album is dropping. I know that many people probably have the day off, and we joke at the Department of Aging that with her Eras tour that this is really our era, and we're definitely seeing evidence of that in our budget hearings that we've been sitting through the last couple of weeks. It's just incredibly gratifying to see and hear the legislature setting agendas that focus on the master plan for aging, that focus on the key outcomes that this committee has developed. We just had a hearing this week with the Assembly Budget Committee about older adult homelessness. Dr. Cashel was able to present. She also presented to the Senate Budget Committee. I don't think she's on today. I'm checking the participant list. But I just want to confirm that your work is so important, and that especially we're in a very, very tight budget situation. And we're anticipating the release of the governor's May budget revision as the April tax receipts are recorded, and we get a better fiscal outlook for the state in the next couple of weeks. But from where I sit, I can say there's lots of attention and focus on the master plan for aging in our 4th year. It is well known and understood by the legislature. It's absolutely being used as a North Star and a focal point for policy and fiscal decisions. And you're a key part of that. So I want to thank all of you very much. When the budget gets tight, as it is, there's 2 things that prevail. 1, personal stories, narratives and experiences, and 2, data and evidence. And in the budget hearings that we've been sitting through for hours in the last few weeks, it is those 2 things that you see legislators take notes on. So we would not be where we are today at all without your support, without our foundation and philanthropic partners, without our aging data dashboard that has been migrated to the California Department of Aging. Thankfully, that's a big milestone that we passed since we last met. And we're so proud of that. And that we're able to be so responsive to the legislature when they ask questions. Sometimes the questions are asked the day before the hearing, and we're able to use, Ross's fantastic work and provide answers overnight. They're at our fingertips. We're able to overlay other factors, equity factors on existing data to really tell the story. So going forward, you are critical partners in our work as we lift up with the Master Plan for Aging Impact Committee. That's the Implementing the Master Plan for Aging in California Together Oversight Committee. Next week they meet, and we'll be talking about how we really can focus on building and sustaining a home and community living system for all Californians, and how we can prevent and end older adult homelessness. These are the things you're already working on in your respective day jobs, but also as a CATERP, what you've been focusing on with the key outcomes. So we see fantastic alignment going forward as the road narrows and we focus. We need you so much to help us focus our work and to ground it in evidence and data. As resources become more scarce, that will help us tell the story. We also have our Equity Advisory Committee that helps us tell the story, and we're exploring the formation of a lived experience advisory board. And that will really help us to tell the personal stories, the lived experience of people who are recipients and end users of these programs and services. And the people, as we are seeing with our home and community-based services gap analysis in our focus groups, people who are not using our services or are not accessing our services and are not eligible for our services or don't know about our services. So we really want to lift up these two pillars, the lived experience and data research and evidence. And so you're critical going forward. You've been critical to get us to today, but going forward, we're going to be leaning more into you and this group to really help us tell that data, evidence, and research story. So that's my message today. I'm just incredibly grateful for the time you give to these meetings and the time between meetings, and your leadership and your expertise always. And just a note of thanks today, and I'll turn it over to Ross.
Thank you, Susan.
And
so
great
well
agenda today too. I'm so excited for today's agenda. So
me too.
I'll be
me too.
watching and listening.
Ross Lawley. Hi, everyone. Ross Lawley. I'm the Chief of Research with CDII. So we're going to kick things off today by providing background information and context about the Day of Action. So Jackie will kick things off, and I'll provide context about recommendations from last Day of Action and kind of some progress to date. So with that, Jackie, may I hand it over to you, and then Callie, if you don't mind pulling up the slides. Thank you.
Perfect. Hi, everybody. Jackie Tompkins. I want to ensure that my audio is coming through clear.
Sounds great, Jackie.
Yep.
Okay, fantastic. That's always step one, to make sure I haven't self-muted or something else is going on. Hi, my name is Jackie Tompkins. I serve as the Master Plan for Aging Project Director here at the California Department of Aging. Thank you for inviting me to join today's meeting. I want to talk to you a little bit about the California for All Ages and Ability MPA Day of Action that's happening this fall, Tuesday, October 8th, 2024, here in Sacramento at the Safe Credit Union Convention Center. While we're still working on the specifics of the agenda, I want to also make sure that all of you on this call who are part of the committee have received a save the date and that you plan on attending. We also want to ensure that we thank our philanthropic partners for helping us support this event. Some of you on this call might be former attendees of this event. We were able to convene a similar event in 2022, and we're doing it again in 2024. So I'm going to go to the next slide to describe a little bit about the event itself and open it up to any questions you might have. And you can kind of keep going forward. There's 2 more bullet points here, Callie. So our, well, I'll just say the Day of Action to make it a little bit shorter for all of you. This is an event that we do every couple of years. It allows us to ensure that the Master Plan for Aging here in California remains responsive, remains flexible to new information, new resources, new projects, and also allows us to ensure that we are being responsive to the highest priorities that are facing the communities that we serve, including older adults, people with disabilities, and caregivers. It allows us to focus that work on those highest priority issues and also ensure that California's Master Plan for Aging continues to embed equity and addresses the needs of older adults, people with disabilities, and caregivers by hearing their lived experience. So during the time we have together at the event in October, we're going to be hearing from our various MPA stakeholder committees, including CADRP. And during this time, committee members will be able to share some priority recommendations. And these priority recommendations will really help us at the state, and speaking with our various state and agency partners in the administration, to help us develop MPA initiatives for the next 2 years. We also use this event to celebrate the progress to date that's been made on California's Master Plan for Aging, and really also use it as an opportunity to continued our shared commitment to California's blueprint for all ages and abilities. We are going to be engaging diverse partners in this opportunity to really reinforce that California's Master Plan for Aging is a whole of government approach, and it's also a whole of community approach. So we're going to have stakeholders, state leaders, federal leaders, community members, consumers, researchers, academia such as yourselves coming to this meeting and demonstrating that, again, the MPA is a whole of government, whole of community approach. Through collaboration, integration, we can advance equity within our state and prepare not only our state, but also be a model for other states across the nation on how to implement a master plan for aging. On the next slide, I want to just kind of share with all of you what we're looking for our various MPA stakeholder committees to do. We acknowledge that a lot of work has been done on the MPA, and we definitely want to celebrate those successes. In that same note, it's also important that we acknowledge that there is so much work more to do to build upon that success and really make transformative systems change to benefit communities, families, caregivers, and individuals. So within the MPA, we have 6 stakeholder committees, and we're asking them to go through a variety of exercises, and each of the committees are at various stages of approaching this. I acknowledge that CADRP has done a significant amount of work to also develop the key outcomes. So I'm sharing this framework with all of you today to see how we can embed the work to date with CADRP into this framework and system. So you all will be able to put forth recommendations at that day of action in fall. So this is just a general framework of how we're working and approaching with each of the stakeholder committees. So we're working with each of the stakeholder committees to basically answer 4 questions. And some of you might be familiar with these 4 questions as they're modeled off of the performance partnership model. It structures about where are we now, having a strong understanding of the baseline of the issues that we're facing. And also in that vein, developing a problem statement that articulates issues, but also uses data to illustrate the problems and issues that are being seen. We also want some input on where do we want to be when we think about the problem statement and the barriers that our communities are facing. Where do we want to be? What does a goal look like at the policy level, the program level, community, person, and the family level? So thinking about what does success look like and how will we know that we have, where do we want to go essentially? And then also talking through, well, if we understand the problem we want, and we have a shared understanding of the problem and a shared understanding of where we would like to be, how do we get there? And so this is an opportunity for our various committees to engage in discussions and brainstorm recommendations, strategies, and priority areas that they would like to elevate, not only here in these meetings, but also at the day of action. Again, we will have diverse audiences hearing this message and elevating the voices of the various committee members. And this is an opportunity, again, to brainstorm the recommendations and solutions and progress that needs to be made. And then also thinking through how will we know that progress is being made on that defined problem. And I think with the data focus of this group, this might come a little bit easier, but being able to have those measurable goals where we can demonstrate that there is progress being made on a specific priority, specific recommendation and strategy. So that's kind of the fourth bullet point, in which we want to be able to illustrate how will we know we got there and achieved a solution to the problem, or at least are making progress towards achieving a systems change. On the next slide, these are some considerations when you are thinking through brainstorming solutions and strategies. This is also just kind of food for thought for the various committee members to help you facilitate a discussion in which we want to ensure that the recommendations being put forth are clear, direct, and action-based to the identified problem and issue. We also want to talk about, when you look at recommendations being put forth, do they align with that equity lens and priorities? Are we looking at priority populations that are experiencing health disparities? Are we looking at making recommendations that are really going to shape some policy systems and environmental change? And through these recommendations, are we also looking at them from that person-centered and even person-led perspective? We also are, want to have discussions when you look at your brainstorming list of how does your recommendations align with the pillars of long-term services and support? And this includes access, navigation, workforce, and financing. And even on the next slide, there's just some considerations to help engage in the dialogue. I have here, again, familiar to this group, is how does the recommendation align with the MPA key outcome measures? Is the recommendation relevant and responsive? Is it timely? Is it really going to address the priority needs that we're hearing from consumers, from providers, and various stakeholders? And also, is the recommendation feasible and realistic to advance or implement over the next 2 years? And is that recommendation also measurable from the standpoint of being a short-term outcome, intermediate, as well as that long-term outcome? And then there's also opportunities to even just think about, if we wanted to put forth this recommendation, it's helpful to also understand what type of resources are needed to actually implement such recommendation, whether this is fiscal resources, staff resources, technology, communications. That also is valuable. And then also ensuring that the recommendation set forth really falls within the scope and the responsibilities of the state as well. And so I'm going to pause there and see if there's immediate questions about the event itself. It really is an opportunity for us to bring together, again, diverse partners across our state and even some federal partners to hear the priority issues of our communities, and also lean into solutions that can help address those priority issues that are being elevated at the day of action. And these issues that are being elevated, as well as the priority recommendations that are being shared with us, will definitely be a guide, provide input to help us shape the next 2025 to 2026 MPA initiatives that we will be working on later this year. Taking a quick moment, I see, hi, Dr. Benton, how are you? Good to see you again.
Hi. I was just having, Susan just said that you're going to be having like a community of people with lived experience board. Will they be part of this October event?
Yes, I'm thinking it's we had talked about in previous stakeholder committee meetings, maybe not necessarily this one, but ones we had last week, was the Aging and Disability Lived Experience Advisory Board. Is that what you're referring to, Dr. Benton?
I think that there was going to be a general, I don't know, Susan just said something about that you're developing a new advisory board of lived experience. And so I just wanted to make sure, I guess my bottom line is that it's important at these events to have people with lived experience attend these events and be part of all the workshops and panels.
Absolutely. I see Sarah has her hand raised, but and then I'll turn over to you, Sarah, really quickly. Yes, we are definitely going to have a consumer panel with lived experience, lived expertise, being able to share their stories, because we understand that it's so valuable to start the day with that foundational setting of the why. Why are we doing this work? And then yes, there's also a two-pronged approach where we're looking to also onboard an aging and disability lived experience expertise advisory group who will also be invited to attend as they're able to. Sarah, I'll turn it over to you.
Great. Thank you, Jackie. I appreciate that excellent overview of the MPA. And Donna, thank you for your question and comment. It's extremely important. We've heard feedback from, state leaders who have said that the most impactful part of our day of action last time was hearing from the consumers. We had, you may recall the whole panel of consumers that were also featured in a video. And this year, what's really exciting is we have consumers that have been engaged through our home and community-based services gap analysis, where our consultant, subcontractor was able to convene listening sessions throughout the state to focus on issues impacting older adults, people with disabilities, and caregivers that tie into the home and community-based services gap analysis. We heard from people in multiple languages, different areas of the state, representing represented communities. And we saw this amazing work that they did and thought, you know what, wouldn't it be wonderful to get some of these people up to the day of action to reflect on, what they were sharing in these sessions, and for us to show that this is how we are trying to incorporate the person's perspective into policy development. Separate from that, as Jackie noted, and as Susan referred to just at a very high level, at our Equity Advisory Committee on Aging and Disability, there was a significant discussion on standing up a lived experience advisory board, as Jackie mentioned. That's something we're really excited about, and see it. It's a concept right now, and we have a lot of work to do to develop, to find resources, because we can't just do this on our, out of thin air, and we want to be very thoughtful in how we approach it. But the idea is that the Equity Advisory Committee would kind of support and facilitate the work of the Lived Experience Advisory Board. The Lived Experience Advisory Board would provide their input, their reflections on key issues that then would funnel up the Equity Advisory Committee would then share those issues and recommendations with all of the MPA advisory committees. So with this committee, with the Impact Committee, with DAC, our Disability and Aging Community Living Advisory Council, with Alzheimer's, et cetera, and Elder Justice. So that's really our approach in thinking through how we can, not just at the day of action, but through all of our work with this committee, really, or with all of our committees and with the MPA, infuse the perspective of the consumer. So one final thing I just want to note into what Jackie said, the amazing framework she put together to help our committees think about how to approach recommendations. As Jackie noted, it could be that the recommendations this committee brings are quite different. They don't have to be policy recommendations. It could be more, and I think that, Ross is going to be leading a great discussion on this, but we want to think creatively. Priorities can mean many different things for this committee. It's not it's advancing research in line with the master plan for aging. So what does that mean for this committee? How does it tie into the work that you think you want to lead over the next few years? So I'll stop there. Thank you.
Thank you for such a thorough and it's exciting to see how it is kind of being infused, as we, how we say we want it baked in. So it sounds like you're really doing the baked in principle. So thank you.
Other questions about the specific day of action? Maybe some of you were previous attendees and have experience attending the event. It will have a little bit of a different look and flavor, but I think the general principle of, again, bringing together our diverse stakeholders and partners, community members, is really the spirit of it, and to ensure, again, that equity component, lived experience is embedded, and hearing those conversations. I know also Ross was going to walk through sharing a little bit about what the committee actually recommended last time and the progress made to date on such recommendations, and then a discussion on thinking about the key outcome measures that you all have already spent the last year working on. How does that fit into a recommendation moving forward as well? So any questions about the specific day? If for some reason you do not have it on your calendars, please let us know. We'll obviously do a quick check to make sure that we have invited all of you. We're looking to have the save the dates be more formalized in May, and then the registration happening in late May, early June.
Thank you, Jackie. I don't see any hands, so maybe we could move forward. And so Jackie did an awesome job kind of setting context for the day of action and what our role's going to be. And I'm going to follow that up with the review of what the research partnership recommended during the last day of action in 2022, progress to date, some of our priority research areas. And then I'd like to hear from you about what you think our priorities should be as we prepare for the day of action. So I have a few slides to go through, then I'll open up for a discussion. So starting with recommendations from the 2022 day of action, I think a critical recommendation where I think we've probably made the most progress on is around identifying beacons and drivers, which offer optimal opportunities to achieve the goals of the MPA. And we've kind of rebranded these as our key outcome measures. And many of you have been on the work groups to kind of help flesh these out, and we'll discuss these further today. The second recommendation was around the development of a research consortium and providing seed funding to encourage collaboration around MPA-related research. We explored this recommendation and we'll continue to explore it to determine the best path forward there. Go to the next slide, please, Callie. The third recommendation was around data and identifying priorities and also reducing barriers to access data, and also supporting the development of state research and data functions to ensure that emerging state data assets enable whole person data capture and exchange. So those were the kind of 3.5 recommendations made last time. I think they were really well thought out and also really important. And we've made progress on these. It also helps as we think about recommendations for this year and next steps. Next steps were also discussed. We can go to the next slide, please. Actually, want to describe those. So in terms of next steps during the previous day of action, building consensus on those beacons, which are now the key outcome measures and associated drivers, indicators, metrics, and also data was discussed. Gaining access to data sources to help develop the key outcome measures. That was a critical next step. Again, we've made substantial progress in this area. We also discussed launching 2 to 3 research projects and hosting an initial working meeting to convene experts and leaders in aging and disability research. So those are the recommendations and next steps. A lot of it was around data gaps, which I think will probably still be a theme for us this year. It makes a lot of sense for the type of work that we're focusing on. For example, caregiving workforce data, direct care workforce data. I think there's significant gaps there. And that was, as we fleshed out those outcome measures, I think that was made pretty clear that there's significant gaps there. So that's an example of a potential recommendation area that we could focus on. So I want to switch gears a bit and discuss progress to date. So I want to start with our key outcome measures. We initially had a set of about 8 outcome measures, and then we narrowed it down to 4 measures based on state priorities. So homelessness, behavioral health, and the paid and unpaid workforce kind of rose to the top in terms of priorities at this point. So the first measure listed there is around reducing homelessness among older adults. So we've collaborated with our colleagues from the Business Consumer Services and Housing Agency, in particular with the team that manages the homeless data integration system. And we've received really informative, comprehensive data from those folks, from our colleagues there. They've been really responsive and really good partners on this effort. The next measures listed is reducing self-reported psychological distress among older adults and people with disabilities. And this measure is being informed primarily with data from the California Health Interview, aka CHIS. And what we like to do there is kind of track over time self-reported psychological distress, both serious and also moderate. And we've been working with our partners at UCLA to obtain updated data. Just about through with that process and look forward to having updated data in the next couple of weeks or so. The next 2 measures are around the workforce. The first one is reducing burdens faced by family and friends. Caregiver is a really important priority area. And this measure will be informed by Caregiver Resource Center data. And actually, Heather and Janice will be presenting on these data today. And after that presentation, hope to have a discussion with you around how to best leverage these data for that respective outcome measure. And also the CHIS data can help inform this measure, but those data won't be available until next year. And then finally, the final measure here is about increasing the direct care workforce. And we're leveraging the census microdata to help understand supply. But we also have some work to do in terms of identifying drivers and understanding how to best implement our equity index here. And I thought it might be helpful to share two of the outcome measure dashboards with you as examples and kind of provide some updates. So I'm going to switch gears and share my screen and share those dashboards with you. Be one sec here. Can you all see my screen? Yeah, okay. Good, okay. So the first dashboard you're seeing, this is our homelessness dashboard, and most of you have seen this several times, but I do want to orient folks who may not have seen this or haven't seen it haven't seen it in a while. So across the indicator, let me start there. The indicator here is folks that are 55 years of age or older who are accessing services while homeless per 10,000 adults over the age of 55. So that's kind of how we're measuring this indicator. And across the top ribbon, you'll see the baseline. So in 2017, 31.3 adults over 55 and over were homeless per 10,000 adults. And that's increased to 59.8, unfortunately, in 2022. As far as the target, we're kind of holding off on setting this target for now. And we have colleagues throughout the state who are working on homelessness, behavioral health, the workforce, et cetera. We want to collaborate with them on these critical issues to understand if they're setting targets. So we want to ensure that that work is consistent as possible with target setting. So that's going to be TBD on these dashboards for now. But something new that we've added is this projection right here. So we took a look at the actual data that we have. And, you know, of course, it's going up, unfortunately. And we have this projection line. It's kind of a simple projection based on the historic data. And as you can see, it's increasing. And so by 2030, the projection shows if there's not interventions, kind of things remain the same. It could go all the way up to 107.6 adults over 55 that are homeless throughout California per 10,000. That rate would increase to that potentially. So that's something new that we added. That's why the status bar is getting worse. Something else, we have this icon here that we added for context. So if you hover over this eye, it'll provide context in how we're measuring homelessness. And what we're doing is using folks that access services as a proxy for homelessness, assuming that most people who are experiencing homelessness will access a service over the course of a year. So that's how we're measuring homelessness. It's not perfect, but we think it's the best data in the state by far. And then we have our equity index here. We've talked a lot about this. This is a critical piece of this dashboard. We added this question mark here. And basically what that does, it provides context about how we're calculating this equity score. We've received a lot of questions about that. So we hope this is helpful. I'm not going to go through it, but this provides some background information about how we're calculating this equity score. And this as a quick reminder, you know, if the score is lower, that means potentially less equity. If the score is higher, that means potentially more equity. So race is the lowest score. So I'm going to hover over that pill here. It's only 19. And this tooltip provides more context on why the score is so low. And the reason for it is Black Californians are experiencing homelessness at much higher rates compared to other groups. And you have that context there. Something new is we're kind of trending out that equity score, so you can see how the equity score is changing or not for this respective measure. It's been flat since 2017, but I think this will be helpful context. So if you go to something like age, for example, it's kind of the same thing, and that equity score has been pretty flat as well, but it adds that more context there. So those are some new features. We have our geographic data. This is by continuum of care, so you can hover over a specific COC to understand what the rate is and that specific area. The darker colors indicate the higher rate. And I think Humboldt County has the highest rate. It's 134 age 55 adults per 10,000 that are experiencing homelessness. Then we also added these drivers here. We had these drivers before, but we added more context. So as an example, if you hover over housing cost burden, that provides context for the consumer and how we're measuring housing cost burden. So it's percent of extremely or very low income, and that's less than 50% of the area median income, and elderly households that are severely housing cost burden. Severely housing cost burden means folks that spend more than 50% of their household income on housing costs. And elderly households is a household, at least one person age 62 plus. The age is kind of tricky because the source data kind of determines what those cutoff ages are. So we added context around the drivers for median rent is the gross monthly rent for households with renters over the age of 60. And then for poverty, that's based on the 150% of FPL. As the California Elder Index gets fleshed out, we're looking forward to replace FPL with the Elder Index. So that's the homelessness dashboard and some of the updates we've made there. I want to just touch on the psychological distress dashboard as well. The indicator here is the percent of older adults that's defined as 60 and older who have self-reported serious psychological distress within the last year. An important note here is that our updated data will include moderate psychological distress as well. So we're going to include that element on this dashboard as well. But it's kind of the same concept. We have the baseline percentage, 3.9, that's increased to 5.4 in 2022. The target's going to remain TBD for now. Then we have this projection line similar to the homelessness dashboard. It's increasing, and so the projection could be close to 9% by 2030. The equity index, we kind of had the same updates. If we hover over gender, for example, you can see the historic equity score. This one's actually decreased over time. And the reason the score is kind of low is because females experience psychological distress at higher rates than compared to males. So we have that context there. Then we have our geographic data. This is by county. Some of the smaller counties up north are also grouped together. You can see the county data. And I think Humboldt County has the highest reported psychological distress. And then after meeting with the behavioral health work group, we added a few drivers here. So the first one's feel safe within their neighborhood. And so this is from CHIS data. This is self-reported if folks feel safe or not. And this is based on folks that are 6 years of age. And so you can see this data has actually been decreasing over time. We also included loneliness, and we only have 2 years of data here, but we still included it. And these are folks that are 60 years of age and older who feel lonely often or some of the time, and then living alone. And this is basically folks that are at least 60 who actually live alone, and that's been flat over time. So that was the updates on our dashboards, and I'm going to go back to the slide deck now. So give me 1 sec. Kelly, could you put the slides up again, please? Thank you. So I just want to wrap up the key outcomes discussion and talk about what our next steps are. I think the immediate next step is to get the outcome measures on our data dashboard for aging. Initially, we're going to post our homelessness and psychological distress dashboards. That should happen really soon. And then the caregiver and direct care workforce dashboards will be posted after that as we work with the workforce work group and Heather's team to acquire the caregiver resource center data and really flesh out the drivers and equity index. We'll be ready to publish those dashboards as well. Really excited to get those published. And I really want to make an effort for the research partnership to have an online presence. I think that's really important. I think our data dashboard might be the right vehicle for that. And we also may need additional data to kind of finalize these measures and or new data sources. And I view this as an iterative process, right? So once these are published, these aren't final. There could be new drivers that pop up we want to include, or we want to place existing drivers. There may be a demographic topic we want to include on our equity index. So the plan is to continue to build upon these dashboards. As an example, with our work around homelessness, we've had initial conversations with our colleagues who manage the homelessness data, and we've discussed comparing first-time older adult homelessness to those who have a history of accessing services. I think that will really help to inform our understanding of this issue. And we've talked about other drivers as well, potentially including disability and or chronic health conditions. So we're going to continue to build upon this work. Go to the next slide, please. So I also want to highlight other progress that we've made based on the recommendations from the last day of action. One of the recommendations was around launching a couple of research projects, which we've done. So West Health has conducted a population survey of older adults. And that was generally about their access, experiences, and opinions. And Zia presented on this topic during our last meeting, and possibly we can receive an update during our next CADR meeting in July. We also launched and closed a survey of the older adult LGBTQIA+ community in California to better understand the community's needs. And this was in collaboration with David's team at Citrus, our colleagues at Open House and at UCSF. And Angie will actually provide an update on this effort after this agenda item. And we continue to have discussions with our state colleagues just around data and collaboration. HCI's Health Payments Database is an extremely rich set of data, obviously. And Mike Valley from HCI provided an overview of the Health Payments Database during our last CADR meeting. And we've had discussions with Mike and his team about submitting a CADR data request around this database. And something I'd like to work with you all, kind of a subset of CADR upon, is developing this one comprehensive data request that can satisfy multiple needs and code to streamline this process. We've already informed HCI that a request is coming. So if you're interested in working with us on developing a data request, please let me know. I think a smaller work group can be an effective way to ensure that we're capturing all the data that we need. We've also had ongoing discussions with our colleagues, the Center for Data Insights and Innovation, regarding the Research Data Hub and how we can collaborate with them. They're working on a lot of important work, but last meeting they described the efforts around homelessness, and there might be a natural opportunity there to collaborate with those colleagues as well. Let's go to the next slide, please. The last update slide I have is related more to CDA, the CDA's research team here. So I'm really happy to inform everyone that we've added a new team member. So Danielle is starting with us in July, and we're really looking forward to adding Danielle. She's very passionate about aging research and is finishing her PhD at UC Irvine. I believe her dissertation is around social isolation of older adults. And for over years, it's just been a team of two, Evan and myself. So really happy to add Danielle. And I see Danielle's role supporting CADRP as needed, but also supporting our data dashboard for aging, or the DDA. So good news on that front. The DDA has been migrated to our MPA website. The DDA is resided on a Public Health's Let's Get Healthy website, but in collaboration with Public Health, we're able to migrate the content over to our servers. So that opens up a lot of opportunity for us. We can really focus on improving user experience, but it also opens up opportunities for the research partnership to have that online presence. And as part of our discussion, I'll have to hear from you about how you think the research partnership can best move forward. Our key outcome dashboards will be on the DDA, but we have the opportunity to add other research partnership related work as well. And then finally, we at CDA are moving toward the centralization of our data assets. So CDA collects program-related data from our AAAs. We work with a lot of demographic data from the Department of Finance, the census, the data dashboard for aging has a wide variety of data from different sources. And so we're working on developing a enterprise data warehouse, and also working on developing more consistency in how we collect data, improve data management practices. And this will lead to vast improvements in how we can interact with these data, and also the ability to integrate these data. So this is a very important step for us, and something that I'm really looking forward to. So you go to the next slide, please. That was a lot of information, but hopefully it's helpful context around the day of action and what the partnership's role is. I would love to hear from you now. If you have any questions about what was presented, happy to answer that, obviously. But I also have a few questions on the screen here. And so from your perspective, what are the highest priority issues facing older Californians today? What areas of research do you think the research partnership should prioritize? What areas of research are you focused on which may intersect with the research partnership? I also would like to hear from you regarding thoughts about the partnership. What's working, what's not working? How can myself and CDA staff improve the experience of the research partnership? What would you like to see? As some of this key outcome work kind of winds down, what's next for us, right? And something that we at CDA will do in preparation for our July partnership meeting is really discuss our research priorities and what questions we would like answered. And I think going forward, the research we should focus on should be a blend of kind of our state priorities, and also what you all, the partnership, see as critical research areas. To be honest, there's some funding challenges right now. I don't think that's a surprise to anyone. We can try and get creative. So really would like we'd really appreciate your feedback on priority research topics, issues around the master plan for aging, home and community care system, housing equity, etc. And then if helpful, the next slide has potential goals and priorities that we can go through to help spur some ideas. And something else that kind of comes to mind in terms of priorities going forward is supporting the other CDA stakeholder committees who are more policy focused. I think potentially our research can help support some of those policy concepts. Before I open it up, I think I'm going to hand it over to Sarah. Did you want to add any context or comments, Sarah?
Yeah, I just want to first, Ross, thank you for that overview. I think it's a really great context setting to get a lot of feedback from all of you. All of you here have been really core members of this effort. And we're super grateful for it. And I just want to say how grateful I am to Ross and Evan for leading this work over the past year and 4 months. I was just messaging with Terry Shaw, how amazed I am at how far this has come. I mean, Terry, who's here with us right now, really was the vision behind the development of the data dashboard for aging. And I remember when I started here, we didn't have a Ross, and I was frightened that we wouldn't find a Ross because I am not Ross and I don't have Ross's skill set, and we couldn't have somebody better leading this work for our team. And that the team's growing. All of you have been critical in providing us such great feedback. I'm amazed to see the progress in developing the key outcomes, and the work in launching the LGBTQ study, the work in that, you know, West Health has led with older adult behavioral health and the survey that they commissioned. So this group has made tremendous progress. And I think there's a few things that I just want to underscore that Ross said. We're in a very different time as a state than we were 2 years ago at this time. So we are very, very, there's another funding crisis that we're facing. So I think that this committee plays a critical role in many ways with this work we're leading in the data dashboard for aging, in helping us refine it, in helping us think differently about it, in helping us advance the key outcome work and identifying where some of the gaps are. And as you've done in the past, in elevating key issues that you see as priorities for research. And with all of that said, we have to just be very mindful of the expectations and the understanding of where we are, you know, fiscally as a state. So right now, I think it's a great time as we think about the next 2 years to say, where do you see this role of the committee functioning, and how might that play into the priorities that you bring to the day of action, which could be built off ones you brought last year. They could be a little different. You know, we're really open to that, and we're open to how you want to structure your work over the next 2 years. And then the final thing I'll say is thinking about membership on the committee. I know we will have conversation in July about committee membership, you know, who is interested in continuing, and just thinking about what your thoughts are on where we need representation and that we don't have. So those are just some thoughts to get us started. And I will pause there and see, Ross, I'll just hand it back over to you. See if there's
Thank you,
questions.
Sarah. Yeah, it might be helpful to pull up those slides, the discussion slide, please, Callie, so those questions are up there.
I also put the questions in the chat.
They're in the
Okay,
chat.
thank you for that. I appreciate it. So it's an open floor now. So if anyone wants to hop right in, or if you want to raise your hand, please feel free. Heather, please go. Thank you.
Yeah, thank you, Ross. And it's such a privilege to be part of this. And I'm also so excited about what's been accomplished in the time. Whenever I think about research and data, I always ask myself, well, so what? What does it mean? How does it matter? And how do we make it relevant to people? And I was really struck, Susan, by your comments at the beginning about data and stories. And we also have stories in data. And I'm wondering if we could focus on how we can really amplify the lessons we learn from our studies of various kinds. So we've got our dashboard, and there's a lot of data there, but then we also have a lot of collaborators in this committee and beyond who are doing work with the populations of interest, who actually may have qualitative data that are very deep stories about people's lives. And perhaps what we need to think about is a strategic communications approach for how we use data to inform decisions, to move hearts and minds in the ways that we need to around this topic. So I would say I'd like to see a recommendation that we start to imagine that and think about how we could really use data for that. The second thing I've been thinking about is how important it is to understand our data. It's not just a matter of specifying outcomes and then we get to figure out what they mean, but tying in with the conversation about wanting to have engagement of the people who are affected, the lived experience, taking the data to groups and asking for their reactions to it. What do they see in it? It's not just what I interpret as a researcher, but when they read it, what do they see as a priority? What do they understand? So it's about trying to bridge the connection between that sort of arm's length relationship we have as researchers of collecting information to bringing it to the populations that we're serving and asking for their interpretation. So thinking about how to engage more deliberately with that. And I think one of the elements we might hear more about if we do that is we've focused a lot on drivers and outcomes, but we haven't talked a lot about barriers and what gets in the way of getting to where we need to be. And we probably should be asking the people who are on the ground and in action to reflect on, where do we need to remove barriers? It's not just forces in the positive sense, but removing negative as well. So I would just like to see some thinking about that. So I'll pause there, but those are some of my initial thoughts.
Thanks, Heather. Go ahead, Steve. I think your hand was next.
Yeah, well, absolutely agree, Heather. And I think besides what you're referencing, I also think we might want to meet with people who are in the community, both directly affected and not, to also think about what information do they want us to collect. Because sometimes we're locked into how we approach the data collection, but much like you're saying, that might not be the key information we need. So we need to also hear from them what they want us to collect.
Thanks, Steve. Go ahead, Zia. See your hand up.
Thank you, Ross. Well, first of all, I want to thank you and Susan and everybody involved for all of the accomplishments that we have together achieved over the last it seems like a year and a half. Time flies so fast. We're going to be meeting again for this Day of Action meeting. I do think that it's time for us to sort of given the background of what's happening at the state level in terms of resources, which actually, in my opinion, makes it even more important that this committee and what we are doing gets done. Because when you have a lot of funding, it's a different environment. When you don't have funding, it's even more important that we make better choices. And I think data and research can really help guide that conversation around better choices and better investments. So I think if anything, it's even more imperative on all of us to identify those gaps. We've talked about what are those gaps. That conversation started with the key outcome measures work, and we sort of started to drill into it. But my hope is that together we can come up with a prioritized list, not a list, but a prioritized list of topics or areas that we can all sort of start to advance. And hopefully have that list ready by the Day of Action meeting that we're gonna be all attending and share that with the state and its leadership. I would love to get feedback from my colleagues who've been really deeply involved in this work. I love this idea of how do we bring more of the consumer side into this and engagement. I know we've done listening sessions, we've done some public polling, but to Heather's point, how do we try to bring in a broader perspective on barriers to care or barriers to certain things, and then really help use that, drive that decision-making around the priority list. Would love to hear from others on how we do that. And then the third thing that you touched upon was the tremendous opportunity with the data resources that the state is already investing in. So the CDII, the APCD, and what is the opportunity there to sort of liberate that data? We've all heard the term of data being in silos. Like, what can we do with the state in partnership to help liberate that data for the greater good? And how do we use it to sort of answer a lot of these really critical questions that face all of us? So I'll stop there. It's a lot. Thank you.
Thanks, Zia. Bella, go ahead.
It's funny, many of my comments directly echo everyone else's and especially Zia's. And I just made a note of something Zia had said before. We're flying blind if we don't have really good data. And one of the most exciting things that's emerged this year is that we will be able to get the data we need to really do a rigorous causal inference and really drill down and answer these important questions about, effectiveness of various interventions, what is really driving this? Where are we getting the most value? So that's the first thing that's really exciting. And, I love the idea that the state itself will be the first biggest beneficiary of making these data available. I think that is completely appropriate. And then the other thought I had around stories and rigorous evidence is in many, many cases, and I think probably especially with something like homelessness and housing, the most effective interventions are also going to be cost effective. So one of the things that, I expect that we'll find is good policy saves money. In many cases, not always, but in many cases. And I think it'll be really important to understand not just what's effective, but where's the most value, so that in a resource constrained environment, we can focus our resources on the things that are going to do the most good. I think I just want to echo also the comment on barriers. I think that is a really important thing to understand, as both the drivers and the barriers. And finally, the stories. It's funny. in another area of great interest to me, like things like road safety, I was thinking a lot about something like Honey, where these powerful stories can really drive policy. And I think the better we're able to communicate sort of how these policies impact individuals, the better policies we're going to get. So thank you, everyone, and really, really appreciate your leadership on this.
Thanks, Bella. I think Donna, your hand was next.
Oh, okay, thank you. I mean, we've really made some great points, and I really want to underscore the stories. I think that is very powerful for people and with the data. One of the things is, and looking at gaps and looking at trends for the future, we know that the family sizes are shrinking at a time when we're pushing more services into the community and at home. But in terms of family structure, people will actually, there's a new report that just showed that families are going to be smaller, and they continue to be smaller, and they're not going to have as many relatives around. So I think that there are things that we can be looking at in terms of data, is kind of making sure that we are following that trend and having that across the board. And at the same time, on the policy end, we have a lot of policies that have limited definitions of family. And so I think that it's important for us to begin to ask the question of people of how are they defining family for them, that may include people that are not under the current definitions, which I think can influence a lot of the chosen family policies. And that doesn't cost a lot of money. So I just wanted to throw that out there.
That's a really good point, Donna. Thank you for that. Catherine, I see your hand up.
Thanks. And yes, Donna, the last point you made, I totally agree. The chosen family, we really need to find better ways to ask questions so people can answer in a way that really reflects their experience and who they identify as family. I also want to step back and just say I'm also really excited about where this group has come. I'm so pleased to be part of this, and thank you to CDA and Terry for spearheading this to get us going. And it really is great to see the progress made. In reflecting across the different goals and the ideas of what research questions we should prioritize moving forward, it really got me thinking about a couple of things, and just to add to what others have already said. And one thing was looking across some of these different sort of topic areas. I think we have to keep in mind how we can find ways to look at the intersections, because there is all of this intersection between the housing systems, between the families, and the direct care workforce, and the systems that also can be looked at using sort of a public health framework. Some of the questions, like you bringing an example of homelessness and looking at those measures of homelessness that you just reviewed, Ross. We're counting people who are homeless, and I don't think I quite understood what services were being used as proxy, but I'm guessing it's homeless services, and that's the proxy. Okay, so thanks for clarifying that. But thinking about going back a bit to prevention and thinking about questions that can get at who's housing insecure. Now, I know you have the measures of, rent burden and so forth that we can look at, but there are other types of sort of housing insecurity questions that come to mind. And if we can get a little bit further upstream to think about how, what is it that's going to help, sort of tipping somebody into actually being homeless, and getting to those questions. Not an easy question to pose, but just something that I want to put forth to the group, and thinking about all of the sort of goals that we have in the master plan for aging. Where can we get further upstream? Primary prevention is ideal. A lot of times people don't think about prevention, just in an ageist way when it comes to older adults. And yet there's so much we can do if we think that way. And I think a lot of our questions and a lot of our markers in the master plan dashboard to date are really looking at sort of the problems that already exist. So we're counting, who's already homeless, who has psychological distress. How can we get ahead of that to look at what are the programs that are going to, delay or prevent psychological distress? What is going to delay or prevent homelessness? So I would just sort of challenge us to think about that, and think about, in the time of resource, sort of not being as resources not being as well available at the state level, think about how we can ask questions that integrate these different questions together, without making a crazy complex research design. But how can we look within housing systems and understand how health and LTSS is provided within those systems, or how it could be provided within those systems to support the consumer, to support the caregiver, the family caregiver, the direct care worker, et cetera. So thinking a little bit about that, and I think those were the main points I just wanted to raise for discussion. So thank you.
Thank you, Catherine. I think Olivia's hand's up next. Go ahead, Olivia.
Thank you, Ross. And I would like to just echo everything that my fellow committee members have elevated. I was thinking of that intersectionality, so appreciate you elevating that, Catherine, just now. But I think kind of the theme of the importance of stories and the lived experience keeps coming up for me, and I'm excited to learn of that new lived experience advisory board, and just kind of thinking through how we can be connected to that, how we can stay connected to that as we kind of contemplate a lot of these research questions, especially, to Steve's point of asking people who are affected what data they want us to collect on. And I think that's really important. And so I know that group is being stood up, and there's probably a lot of planning that still needs to happen, but just I'm curious of how that will look, how our connection with that group will look as we kind of move forward on a lot of these things.
Thanks, Olivia. Susan, go ahead.
I am just appreciating this conversation so much. I was gonna direct message each of you after you spoke. Yes, you're right. Spot on. Agreed. I want to hone in on something Catherine said too, and this is relevant to this week's budget hearing, where the state faces, we're looking at the population right on our doorstep in front of us. And also from the budget committee perspective, what can we be doing upstream for this, the growing population, and what early interventions can be made. And that is entirely new thinking in the aging space. That's historically has not been, there's not been much of a preventive model and a risk and harm reduction model. It's been more an intervention model. So I really, there was a call for that in the budget hearing by Assemblymember Jackson about, we're going to do everything we can to protect vulnerable populations. He called it our sacred responsibility, terminology I just absolutely loved. But also, we can't do that at the expense of what's on the horizon. And so I know, there's a lot of, I'm trying to think of the exact term that, fiscal pressure on the state is the term that's often used, is, what can we do to reduce the fiscal pressure on the state with some preventive and earlier interventions and preventive strategies that have proven very effective and impactful with other populations historically, where there's a clear commitment to getting upstream and using public health approaches. So I'm very intrigued by that notion. And I think of, temporary rental assistance as, just one example, that comes up repeatedly in for people who are precariously housed to prevent homelessness as an example. So some of this could lead to lower cost options, potentially.
Thanks, Susan. Zia, go ahead. See your hand up.
Yeah, I wanted to follow up on what Catherine and Susan have said, and I'll use the example of some of the work we are starting in behavioral health. We really think of this as a lifespan problem. It's a lifespan approach to behavioral health. People don't just turn 65 and have mental, diagnoses. They've probably had it for many years before that. And so from a preventative perspective, I think interventions that start earlier on definitely have an impact on older adults and their lives. So I think for all of us to think about this broader than sort of having a segment of population only, but to think about the interventions, whether it's around housing, focusing on not just what's happening for older adults, but what's happening for families and younger populations, same for behavioral health, will really help us prevent a lot of this from happening in the long run. So just want to bring that perspective. I couldn't agree more that we have to think outside of just older adults to really help them get better.
Yeah, to that point, Zia, I think that the more we can use data that's looking at population projections, I think particularly around equity, when we think about what the trends are in our state, and both Donna and Catherine really eloquently identified a couple of those important ones. We do have in the state, in a different silo, the Department of Finance data around population projections at a pretty micro level that we typically don't bring into a lot of our planning and thinking about it at a programmatic level, but it's highly relevant. And I think to the extent to which we could identify an horizon as we're looking at this, is it 5 years, 10 years, and do some real thinking and modeling around where is our population going a little bit, and at a macro level, and then of course there'll be more micro level thinking about it as well. But that's a really important trend. What Donna raised about family size, big issue, and allocation of resources across the lifespan will shift. And what do they need to look like? And so that's something we haven't really gone far out in this committee in thinking about, but I think it's really warranted at this time to start to think about that.
Great points. Zia, go ahead. Is your hand up?
Oh, sorry. No, I didn't.
It's okay. Don't worry about it. Thank you all so much. This is such a rich discussion. Great points raised. There's some themes, I think data gaps, stories, those early interventions. So what I'd like to propose, we could do, I could email you offline.
One quick
Go ahead,
second.
Steve. Yep.
Yeah, I'm, this is a great conversation, so thanks. But I'm also wondering, besides tracking the data, do we have a way of also thinking about what do we need to respond to address the upstream issues and the long-term issues? Or is that something that one of the other committees is going to do in terms of what kind of programs would be necessary to work? What kind of leadership workforce development do we need? Because if we're just going to have the same approaches to the infrastructure building, then we're probably going to get the same kind of thinking and the same kind of results. I mean, it's that old comment, if you use the same thinking, you're going to keep getting the same results. So I think we need to use the data to challenge ourselves to think about what do we need to do upstream, but also what do we need to do differently in a community that may not be anything to do with a government service.
That's within the scope, I would say, Steve. I think that's a really good thought. And so what I'd like to propose is maybe having a smaller work group, and if you all want to join, that's fine. But we could talk about this day of action recommendations and flesh these concepts out, because I heard really, really good themes, and we'll send some notes out. How's that sound? I can connect offline via email. And if a few would like to join that work group, I think that would be really nice to flesh this out. Thank you so much. I think this was a great discussion. I really, really appreciate it. Was there anything else? I know we're over a few minutes, but okay. So thank you all. We'll follow up on this great discussion. So I think our next agenda item, Angie's going to go over our LGBTQIA study and next steps with that. So Angie, I'll hand it over to you.
Wonderful. And I'll just say this was a very well-designed agenda, because I feel like this conversation about this study fits really nicely after this very recent conversation. So this is, I'm just going to give some updates about the LGBTQIA plus same gender loving study that I mentioned, I think, one of the earlier meetings. So this, just to sort of refresh, there's a statewide survey that closed March 31st that was collecting data from anyone LGBTQI plus same gender loving identified 50 and above. And we intentionally chose 50 to kind of recognize the realities of accelerated aging, particularly in this community. And so we had a target of, I think it was something around 2,500, and we ended up getting close to 4,700 responses, which was a really excellent response rate. These are preliminary numbers, by the way. And it's not a representative sample, just to keep that in mind. And I say that for a couple of reasons. So one, we have an excellent response rate, and we have folks from all parts of the state who have responded. And also we have some gaps in terms of race, ethnicity, linguistic representation. So we're going to have a lot of really rich data. And of course, we want to supplement this with precisely everything that folks said here, with more community voices and stories from the data. So we have a second component, which we've just recently started, which is the qualitative study. And that's going to be comprised of 10 to 14 focus groups throughout the state of California that specifically targets more underrepresented communities within sort of this larger LGBTQI plus same gender loving larger umbrella. And so we have that, we've started that, and there are 3 recruitment, I guess, strategies that we have. One is through the survey. We asked a question at the end, which was inviting participants who wanted to participate in the focus groups to let us know. And then we have a process for targeting individuals for particular focus groups. And so we had 400 people identify that they wanted to participate in that. So plenty of folks from that avenue. We have a second avenue of recruitment that stems from, we have a community advisory board that's made up of LGBTQ plus organizations throughout the state. And they're helping with outreach and recruitment. That also is building on what they've already developed through a coalition for the survey. And then we have a third recruitment strategy, which is building on relationships and connections with community partners that are not necessarily specifically focused on serving LGBTQ plus folks, but maybe focused on older adults, or maybe focused on racial or ethnic or linguistic underrepresented communities within the state. And so we have these 3 different arms of recruitment that are happening simultaneously. And so far, I mean, we really just kind of started this qualitative component, but we've had some really significant interests. And a big part of it is because I think it's the exact conversation we just had, is wanting to have the stories elevated, the experiences elevated. And for some folks that we've already talked to, it's the first time they've been invited to participate in something like this, or they feel that they've been invited to participate in something like this. And so it's been a very impactful, even just the recruitment process has been, it seems to be pretty significant for a lot of folks. And then I'll add that we've been really intentional about incorporating community partners through the design, both methodologically, but then also of thinking about what questions to add, what questions to ask. And so we have certainly a pretty significant health focus, given sort of the needs of what a lot of folks have said and where we know there are gaps. And also thinking about, what does health mean? Social determinants, drivers of health. And so based on that and conversations we've had with community members, we actually included a series of questions relating to caregiving and housing. And housing was initially not on the radar of some of the, I think some of the collaborators on the team, but it became very foregrounded after having sort of initial conversations with community members, especially knowing what we know about what's happening with housing affordability and instability among older adults and beyond in California. And so that's been, I think, a really important addition based on community input. And then the other thing I'll add is that the intersectionality piece that was raised earlier, I think, is a really important component of this particular element of this study, because we have focus groups that are comprised of folks. There's comprised of folks that are sort of based on a particular sort of what they have identified as a salient positionality or identity or social location. So for example, we have one focus group currently that's looking at, or it includes Black same gender loving older adults. And yet within that, of course, there's all sorts of other sorts of positionalities. And so we've incorporated within our questions discussions about how these sort of intersections are shaping their access and, thinking about barriers, thinking about also community elevated solutions and things that are currently happening or should be happening. And so I think it's going to be, I'm really excited about having this opportunity to sort of, respond to all of these things that are really, that have been foregrounded within, at a community level. And now we have the opportunity to sort of elevate it to services and policies. So I think that is probably a good overview of what we've done and where we are and where we're going. And so I'll have a lot more to report at our next meeting since we just really started this phase of the process. But very excited. And I know a lot of folks here have been supportive about this project, and that's been really wonderful. I'll just note, I think it's maybe the next slide, that if you do have, the next slide, that if you do have any particular community partners that you think would be really interested in this, don't hesitate to reach out to me. I have my my own email here, and then also we have a general email for folks that we're using, just general inquiries about the project. But welcome to reach out about that. And in terms of timeline, we are hoping to do most of the focus groups over the summer and possibly some over the fall. Again, we're thinking from a community perspective. Some folks want to attach it to various events that are happening. And so some of those events are happening in the fall. So we're trying to sort of be very responsive about what works best for different community partners. And then the plan is to have all of the data analyzed and have some actual products by the end of this year, 2024. So happy to answer any questions, but again, expressing my deep appreciation and gratitude to folks on this team and beyond for helping make this possible.
Thank you, Angie. The response rate was phenomenal. We're so excited about the focus groups. We dig in those survey responses. Any questions? I think we have maybe a couple minutes. Anyone has any questions?
Great work.
Thank you. Okay, we can move on if I don't see any hands. So our next agenda item, Heather and Janice are going to present on our caregiver burdens data, the caregiver resource center data. So I'll hand it over to you. I think, Heather, are you going to kick things off, or Janice?
Yes, I'll be kicking it off. Thank you, Ross. And I'd like to welcome my colleague, Janice Bell from the University of California, Davis Family Caregiving Institute. She's the director at that, and we're close colleagues working on a number of different projects with the California Department on Aging, evaluating a variety of key initiatives. Next slide, please. So this is tying into our workforce work group work that's looking at family caregiving and the burdens associated. And I just wanted to bring this slide in to remind everyone about what we've been discussing as a group around drivers and outcomes. And we've been grappling with how to get to the data. As many of you know, caregivers, there are about 5 million caregivers in California. And finding those people and getting their perspectives is a really big challenge. So as we've grappled with it, we started out thinking about working with the CHIS database, the California Health Information Survey, interview survey data, but it has its limitations. And then as we thought about it further, we realized that we have a very deep and important and informative database that we can use to analyze some of these questions. And we want to share that with you today. Next slide, please. So at the Family Caregiving Institute, we're engaged in evaluative work with the California Caregiver Resource Centers, and we're also in the process of working on an equity plan for caregivers for the state, using some of the data that we'll be sharing with you today, and then data beyond that as well. Next slide. Our overarching model is really based on the stress diathesis model of caregiving, which is a longstanding model in the field. But it has been honed in our work with AARP and the Public Policy Institute as we've tried to get our arms around understanding what's going on with caregivers, understanding the kinds of supports and services that they need and that they access, and how all of that impacts their quality of life and their health outcomes. So our model focuses on understanding who are the caregivers in the first place, and that's not a simple question because many caregivers are invisible or they don't identify as caregivers. We also are interested in what they're doing, how do they feel about what the care that they're providing, and what resources are available to support them. How does all of this put together affect quality of life, and then ultimately health and well-being for caregivers. So I'm going to talk a little bit about the data source, a CareNav, that we're going to be describing in the next slide. The Caregiver Resource Centers were formed in California in 1984 as an initiative that was intended to provide access for caregivers across the state to services and supports. There are 11 centers now. In 2019, there was an invigoration of funding that included implementing a statewide database, as well as a number of other elements of improving supports to these services, to caregivers in the state, and to really look at centralizing a lot of the ideas behind the data and the information that we could use to deliver care. This map on the right depicts the regions that the 11 centers serve, so you can see it covers the entire state. And core programs within these centers include specialized information, caregiver assessment that's uniform, a standardized assessment, the provision of family consultation and help with care navigation, respite care, and a variety of other services and supports. The funding sources are varied. There's some CDA funding, there's 3E funding, variety of different private philanthropy and other kinds of contributions from the community. So the funding sources are quite diverse. Next slide, please. So with the CareNav system, which was developed by the Family Caregiving Alliance, and it has now been deployed across the state starting in 2020, it's a client record system, which is really quite unique. It's something that's available, very rarely available in community agencies. It's a cloud-based and HIPAA compliant. And what it does is enables the family care consultants to collect information in a standardized way, assess caregivers who are interested in services or supports or advice, collect that information, and it enables it also reassessment. It's also on a portal so that caregivers themselves can go in and enter the data themselves and have the opportunity to submit their information. And after the information is submitted, there's a dashboard that's tailored for that client. So it will highlight what's going on for the client and identify particular resources that might be useful. So if someone says they're having trouble sleeping, some resources about sleep might come up to be able to help them to navigate that issue. It also provides the platform for the family consultants to develop a care plan with the information that's relevant to each caregiver. It's secure, and importantly for us and for the purposes of today, we're able to generate reports and export the data for analysis. So we want to give you just a little bit of a flavor for the data so that you can see how this could be useful in looking at our questions that we have in the monitoring of the Master Plan on Aging. So in fiscal year 23, we had over 4,400 caregivers enrolled newly into the system. And as this slide will show, there's a great diversity of caregivers across the lifespan, age-wise, by gender, and then also race and ethnic groups. And this is really important because there's sufficient numbers in these different racial ethnic groups that we can actually do sub-analyses in these areas, which is often not possible with large databases that are not as well represented of the total population. Next slide, please. We also understand a lot from this about characteristics of the caregivers. The people who raise their hands for help with the CRCs are definitely those who are delivering the most high, intense, and time-consuming care and complex care in the state. About a third of them are working full-time, and many are working part-time as well. They're having effects on their employment, which is a really important issue, not only in the present for their financial well-being, but also for their own future and their accrual of benefits and pensions. The types of relationships people have, many are partners, but they're also children, adult children, and other relatives providing care and friends. And as we think about family, consistent with the previous conversation, family is defined by the person. It's not any other kind of definition. About 20% are below the federal poverty level. And so you can see that there's quite a bit of diversity within this group. And Angie, I'd love to connect with you more as you look at the sub-analyses of caregivers in your data set, because as you can see, we have a predominantly heterosexual group in the CRCs as they identify. Next slide, please. So now thinking about some of the drivers, when we think about what drives burden for caregivers, one is simply time and energy. This is a group that's providing an incredible amount of care. Over almost 3/4 are doing 40 hours plus a week. And AARP has been able to come up with an intensity index that relates both hours of care with the types of services and supports caregivers provide. And out of that, the highest level you can possibly be with intensity is a 5, and 2/3 of this population are at a 5 in their intensity of care. Importantly, caregivers are really going it alone. 69% receive no paid help at all, and almost half get no unpaid help, meaning that they're isolated. They're not even embedded in a network that's providing additional supports. And the trajectory is long. As you can see here, the caregiving duration, more than half or have been caring for more than 2 years. So it's a long-term commitment. We've been doing some deeper dives into the subpopulations to get a glimpse on equity issues as we're starting to work on the equity plan for California. And I'm going to turn it over to my colleague, Dr. Bell, who will share with some of us the next slide and some of the findings we have on equity.
Thank you, Heather. So this first slide is showing that index that Heather talked about, the AARP measure of caregiving intensity. And what you see across the graph is how red it is. Those are the caregivers that are involved in the highest intensity category, so 4 or 5. And you can see across the board, about 90% at least are in that high category. But we also see when we split it by age that the intensity is increasing slightly by age, and that there are differences by race and ethnicity, with caregivers who are identifying as Asian American and Pacific Islander, Black, non-Hispanic, or Hispanic or Latino having slightly higher intensity of care than their white non-Hispanic counterparts, and certainly caregivers below the federal poverty level having higher intensity than those living above. Next slide, please. So this is one of the drivers of that index, which is the number of hours that of care that people are providing per week. This is showing caregivers providing 40 hours or more care a week. And again, we see that increasing with age, possibly because there's a lot of spousal caregivers in this data set. And certainly as age increases, people have more time on their hands in terms of retirement and being able to care for one another. And then younger caregivers have competing demands like caring for young children and jobs. Then again, you see the hours of care is also, again, varying a little bit by race and ethnicity. And there is that jump with caregivers below the federal poverty level being more likely to be doing 40 hours or more of care a week. So these are just thinking about different categories of equity. Next slide, please. This is looking at the mean number of medical or nursing tasks that the caregivers are doing. This is from a pick list of about 10. The tasks include things like monitors and meters, using oxygen in the home, doing wound care. So these are tasks that are often thought of as tasks that nurses or providers would be doing. And you can see that it's the younger caregivers who are doing slightly more mean medical tasks than the older caregivers. Again, differences by race and ethnicity, with white non-Hispanic caregivers doing slightly fewer, and people below the federal poverty level doing a little bit higher mean number of those tasks. Next slide. This one is looking at hours of paid and unpaid help. And again, what I'm struck by when I look at this is how most of the graph bars are really light blue, which is having no paid help or up to 10 hours of paid help or unpaid help. So the unpaid help is on the left and the paid help is on the right. So most caregivers having less than 10 hours, the percentages again differ by race and ethnicity. And in graphs not shown, we saw less unpaid help with older age, less paid and unpaid help with lower income, and less paid and unpaid help with rural versus urban residents. So it seems like everything we're looking at, the way things split out, it seems to be similar by category. The next slide, this is looking at the Zaret Caregiver Burden Scale, which is one of the assessment and reassessment items. It's a 4-item scale asking the caregivers if they feel strain, stress, have no time for themselves, or feel uncertain about what to do. And here we see some differences by race and ethnicity. This has been documented in the literature too. It has something in some ways to do with how different groups feel about the caregiving role and how they endorse those different items. And also we saw higher burden with younger caregiver age. Next slide. This is looking at the caregiver's health compared to 6 months ago, with red being worse, yellow being the same, and green being better. And more than a third of the caregivers report their health has worsened over the last 6 months. That percentage is higher with older age. It's higher among caregivers who identify as Asian American or Pacific Islander, and it's also higher among caregivers with low income in a graph that's not shown. Next slide. So some of the other variables that are in this data set include the standard medical outcome survey question of, would you say your health is excellent, very good, good, fair, or poor? And about a third of the caregivers in this data set rate their own health as fair or poor. Similarly, about a third say their current health is worse than it was 6 months ago. About 20% are saying that their depressive symptoms are moderate or moderate to severe, and that is using the PHQ-9. About 1 in 5 are saying that they're lonely, and that's based on the UCLA loneliness scale, which is a 3-item scale. 60% are scoring as having high strain on that 4-item Zaret burden. And a third say that they're satisfied with the support they get from family and friends, meaning the rest say they're not satisfied, and about 44% are saying they're satisfied with the spiritual support they receive, so more than half saying they're not satisfied with that. So in closing, the strengths of this data, it's a large data set that's growing every day. It's updated in real time as care consultants are doing assessments. And so it is getting to be quite a large data set. It includes caregivers with the highest needs, so certainly highlighting sources of strain and other outcomes that could be modifiable and maybe worth tracking. And then, of course, it's longitudinal on the subset that do get reassessed. In terms of biases, it's a sample focusing on caregivers with the highest needs. And we have used the California Health Interview Survey for some of this work and did a comparison. That's a population-based sample, and those caregivers have far less need in general. So it's the question remains like, are we capturing a representative sample of caregivers when we're looking at a representative sample of Californians? And then when we're looking at this data set, we're looking at those in the sort of tail end of the bell curve in terms of need. And I think that's the end of the presentation. We're happy to take questions.
I have a question. So thinking about the key outcome measure on caregiver burdens, it was kind of this broad measure, right? Using the CHIS data. I know this sample's biased because these are folks that reach out for help, right? But I was looking at the caregiver strain and also I think the intensity of care. And I was curious with our outcome measure, if you think it's appropriate to maybe focus on folks that have that more strain. I get like that slide on strain or the high intensity care. There might be some correlation there as well, right? Like high intensity care and maybe the strains are higher. So just thinking about the outcome measure, is it appropriate to maybe focus on those populations, folks that have the higher burden strain or the high
I think
intensity?
they're both useful measures, and it could be that it's more like it's useful to look at them side by side because they are measuring different aspects. One is very much about the hours and the sort of tasks provided, and the other is how you feel about it. So I think they're kind of capturing different dimensions of the caregiving experience.
Okay, thank you. That's a really rich data set. Thank you so much for the presentation. Appreciate it.
Mm-hmm.
Donna, do you have a question? And I want to thank Donna because she's one of the contributors of a huge amount of data from the CRC that she's leading.
Yeah. No, I've seen this data. It's always refreshing to see it again. But kind of what Ross was saying, one of the things that we find with caregivers is that it is important to get the perceived amount of strain versus what we do more with the objective measures. Because when you look at, we have some caregivers where they could be doing 5 very intensive things. And when you ask them, how much does this bother you? They're like, nope, not at all. Mm-hmm. And then you could have somebody who's, just the opposite, and they're doing one thing and it's highly stressful for them. So that's why we always have those things in tandem. And if you look at the memory behavior checklist, it uses a similar model when you're doing a memory behavior checklist. And so that's why, just to underscore what Janice is saying, that you have to work those two separately.
Catherine,
you have
a question?
Thank you for that. That was a great presentation and really rich data. I'm curious if there are other indicators that are not included in what you presented today. And in particular, I'm curious about whether the CRCs systematically gather information about how the caregivers get information that they need, or, you know, connections to services for the people they're caring for.
Short answer, yes.
Okay.
Yeah,
I just
yeah.
think that could be really informative. That's why I'm asking. I'm curious because it's a good data set. It might really give us some information about pathways to access to care.
Yes, in CareNav, there's some of that information, and we also, in different ways, collect additional data around service provision and supports, and also about from caregivers directly around their satisfactions with the services and where they see gaps might be. So it's a very robust data set that we're happy to talk more about with all of you.
Wonderful, thank you.
Yeah. Heather, also the CalGrow's caregiver training that's been going on for the last year, they've been capturing a lot of really important information as well in terms of not only how they want to learn the information, but what information they want and how to organize it. So
That's
that would
absolutely
be some
right.
more information as well.
Yeah, thank you, Steve.
Do they break that information out according to whether it's a direct care worker versus a family caregiver?
They've been tracking paid and unpaid caregivers.
Pardon?
They've been tracking it in terms of paid so that they're working for an agency, and then also family and friend,
Yeah.
so that you'll have it separated.
They do have it separate. That's great.
Yeah.
Heather and Janice, how would a caregiver find out about these resources, like the CRC resources? Like, is there promotion and marketing involved?
Yeah, there's quite a bit of promotion and marketing. And there's also a statewide database that a statewide website where anyone can go and they get referred to their local region where they would be able to access it. But we're finding when we ask caregivers, how did you hear about it, that a large number hear about it through referrals. So I think we have a lot of work to do for healthcare providers and community agencies to help them to be more aware, to drive traffic towards the caregiver resource centers. And then word of mouth from caregivers themselves to each other is another big source.
And I think part of the equity plan, the work that we've been doing, is also trying to identify strategies for getting that word out even further and trying to identify groups that may be systematically not served at the same rates. It's really a very difficult thing to do, but I think that I think Texas are doing a big awareness campaign. So there are other models in other states for thinking about how the word can get out for these very important services.
Let's see Catherine's hand. Go ahead, Catherine.
Thanks. I just had a follow-up question. And so I actually did my master's internship at Family Caregiver Alliance like a long time ago. And so I don't know exactly how it's evolved over time, but my understanding is that the services are really the mission, the mission of the organization is to serve the caregivers and support their needs. But I'm curious about whether there's some translation to what the person they're caring for needs, and some tools that are given to the caregivers that help them identify resources that can help the person that they're caring for.
Yeah, with the kid. Oh, I'm sorry. Is it okay if I answer?
I love it, Donna. Please do. I was going to ask you if you would.
Yeah. So the care plan is a combination of both what the caregiver, with a focus on the caregiver, but often if the caregiver needs information about the person they're caring for or resources for the person they're caring for, that's going to get that information to them. So we have a deep database on both sides. The caregiver emphasis is more around getting wellness and taking respite breaks and things like that. So that's where you try to help the caregiver, but the information is very often, because people come to us not because they're caregivers, they come to us because they're calling about the person they're caring for. And then we help them self-identify after that.
Thank you
And
for-
something about culturally, we have things are in so many languages. We have a lot of languages that are across the statewide system, and information in many languages, and also making sure that it's also appropriate for educational levels. So things are done for 6th grade education levels and a lot of things like that. And rural, urban, we've got all kinds of junk. It's 30 years, it's almost 40 years of services, so we've evolved a lot.
Go ahead, Zia.
No, first of all, thank you so much for this presentation. Very informative. I'm coming at this from a clinician's perspective. I know that Medicare has, proposed new billing codes for providers who are going to spend time with caregivers on educating them, training them, supporting, providing some coordination services. Is that something that you guys are exploring or learning about, or have any information on?
We know there are 4 new billing codes for training, and part of the 4 billing codes, what they can do a referral to our services. So that would be one of the areas that we're looking at in our strategic planning, is how to work with that when they do those referrals for support groups and training programs, because we have evidence-based training programs and lots of support groups. But the physician, those billing codes, they might choose to do those in-house also, so.
Yeah, I'm wondering, Donna, if there's an opportunity to do some education around this for the physician provider community, but I don't think many providers are either fully aware of these codes or
Yeah.
use them.
Yeah.
Which I think is a shame.
I think that's a really big opportunity. Yeah.
Thank you, Heather and Janice. That was an awesome presentation, very informative, rich data set, and I look forward to working with you in the workforce support group, understand how to bring these data into that outcome measure. I have some ideas written down, but I'll follow up. Thank you so much.
Right, thank you.
So Carol, I think I'm gonna hand it to you for public comment. That's next. We're right on time with the agenda. Thanks.
Yes, we are right on time. Thank you so much. So we will move into our public comment section of the agenda at this time. For our attendees, if you have a public comment, you may press *9 on your dial pad if you're appearing at the meeting by phone, or on your Zoom meeting bar, click the raised hand icon. And so we first have Harriet, ARONOW. Harriet, you can unmute your line and give your comment, please.
Thank you. My name is Harriet Aronow. I'm a research scientist at Cedars-Sinai Medical Center, and I've had decades of research in mostly in preventive and health and well-aging, both well-aging for older adults and well-aging for people aging with disabilities. I'm struck by the conversation today, as I have been recently in our own research, by the fact that we have focused on getting data on individuals, which is very valuable and does describe what needs are. But I'm beginning to realize that we need to include in our research and our data gathering different levels of context. The things like the structures that older adults have to work with that contribute to the inequities in access to services. The most recent example is we're working with a group of low-income older adult housing apartments, doing some well-aging research, and I've been struck by who gets into the low-income older adult housing buildings. and it doesn't reflect the race, ethnicity, and and sort of family structure or generational structure of the surrounding areas. So I think that it would be valuable to focus the group on collecting data on things like how difficult is it? What are the processes for getting access to services? What's the paperwork? What's the level? What's the literacy level of getting insurance, Medicaid, Medi-Cal services, getting into low-income housing, and then what can be done to simplify or make those processes more equitable?
Thank you so much. I've also put the Engage email address into the chat, so feel free to lift that up if you would like to expand and provide more context to that. Send the committee a written public comment. Please do so.
Thank you.
Thank you so much, Harriet. Have we anyone else? This is our public comment period. It's been a rich discussion today for sure. Okay. Let's give it another moment or two. Again, feel free to email engage@aging.ca.gov at any time. We're happy to forward the information to our partnership, to Ross, to manage that information. If you have any other comments that come to light after this meeting ends. Okay, Ross, I'm gonna spotlight you. If we have no more, I see someone's hands up.
I think Zia's hands up, but it might be from before.
Okay.
Zia, is that right?
Oh, looks like we're
Okay.
cleared out. Okay, Ross, why don't you go ahead and close us out?
Sure. Thanks so much, Carol. This conversation was so awesome today. Thank you all so much. The feedback, the discussion was phenomenal. So the next CATR meeting, July 19th, and before then, we're going to publish the homelessness dashboard, the psychological distress dashboard. I'll work with the workforce work group to determine how best to include the caregiver resource center data and flesh out drivers and equity index, all that good stuff. And also I'll reach out to the group about the day of action. Maybe we could have a smaller planning work group and report out at that July 19th work group meeting. And I think Bella, I'm going to reach out to you to like kind of maybe have a couple of research partnership members work with us to flesh out that data request for the health payments database. And maybe we can report out on that on July 19th as well. So thank you so much for joining today. Really enjoyed the discussion. And I think that's going to wrap it up, Carol.
Yes, it is. We are
Okay,
good. Thank you
great.
so much for coming.
Thank you all. Have a good weekend. Bye-bye.